Hello everybody. This is the second of a series of lectures on imaging biomarkers for prostate cancer. In this lecture we will focus on the regulatory view on developing imaging biomarker, and I'll try to demonstrate that regulatory requirements for biomarker approval differ from the steps needed to build clinical value. So let's start with a summary. In the first lecture, we talked about the four major types of biomarkers: diagnostic, prognostic, predictive, and response biomarkers. So diagnostic biomarkers characterize patients by the presence or the absence of a disease or a subtype of the disease. A prognostic biomarker informs on the likely course of a disease in an untreated but diagnosed individual. A predictive biomarker categorizes patients by the likelihood of a response to a particular therapy, and a response biomarker shows a biological response in patients after having received a treatment intervention. In the first lecture, we also made the distinction between a prognostic and a predictive biomarker and what they are used for as far as prostate cancer is concerned. Prognostic biomarkers, as I've already said, informs on the likelihood of a future cancer outcome. So prognostic biomarkers are used to identify individuals with either a very favorable outcome or a very poor outcome, where usual therapies and dose escalations provide no added benefits and you need to use some other strategies. Whereas predictive biomarkers are used for the usual types of patients, because oftentimes in prostate cancer there are multiple therapy options and it's not always clear which treatments to use, and we know that outcomes need improving. So to decide on which therapy to use. Now, when we develop an imaging biomarker for prostate cancer, there are usually a number of steps. There is the analytic validation phase, followed by regulatory qualification. And in regulatory qualification, what you do is go from clinical studies to clinical qualification, where there's a potential for health decision making. But remember that clinical development or clinical value is built only after this stage, when you can show that the imaging biomarker resolves clinical problems effectively. So in terms of the regulatory approval process, there are 5 major things you need to think about. One is a need statement. What is the knowledge gap that the biomarker is addressing? And what is the context of use? And the context of use depends on the type of biomarker. And then what is it that you're going to get for patients? What are the benefits for patients? What are the risks for patients compared to the current methods? And the combination of these factors will determine the level of evidence that you need to qualify for a use. And so let's consider each of these steps in turn. So the whole thing starts with a need statement. What is the knowledge gap being addressed? And then you have to define the context of use, the level of evidence, before you can reach the qualification step. And the qualification step is a conclusion that the biomarker can be relied on to have a specific interpretation and application. The need statement is a concise and coherent description of the knowledge gap that the biomarker could fill. So if you look on the right-hand side, you can see a graph showing that the higher the PI-RADS score, the greater is the probability of clinically significant disease. If we take a positive MRI, you can see that within the PI-RADS 3 category, 84% of men in the PI-RADS 3 category do not have cancer, and in PI-RADS 4 and 5, about 35 to 40% of men do not have clinically significant cancer. Taken together, we can see that about half of the men with a positive MRI do not have clinically significant cancer, defined as Gleason grade group 2 and above. So to address this particular need, you may be able to use both the MRI suspicion score plus PSA density to reduce the number of unproductive biopsies. So you would need a diagnostic biomarker, and we said a diagnostic biomarker categorizes patients by the absence or presence of the disease. The biomarker example in this particular instance is the MRI suspicion score plus the PSA density, and the context of use is improved patient selections for biopsy. Regarding prognostic biomarkers, we said that these provide information on the likely course of a disease or condition. An example is the extent of bone disease on a bone scan and its relationship to the survival outcomes. You can use this to risk stratify patients likely to have a worse or better outcome. So if you look here, for example, you can see that the greater the disease burden on a bone scan, the worse is the survival probability. Here is low volume disease, here is high volume disease. You can see that patients with lower volume disease have a better overall survival than patients with a higher burden of disease. But if you look at the hazard ratio, you can see it's exactly the same. So this biomarker is in fact prognostic, and it's prognostic regardless of nodal status, Gleason score, age, or the performance status. So you can use this type of biomarker to risk stratify patients likely to have a worse or better outcome for entry into clinical trials or for the analysis of the results by prognostic groups. And here is an example. So this time the clinical setting is the same, metastatic hormone-sensitive prostate cancer, but the drug treatment is different. Abiraterone compared to docetaxel previously, and you can see that this biomarker also predicts for benefit, looking at overall survival and failure-free survival in low-risk disease and in high-risk disease. So this biomarker is prognostic for docetaxel and now for abiraterone in the setting of metastatic hormone-sensitive prostate cancer. With regard to predictive biomarkers, we said that these help characterize patients by their likelihood of response to a particular therapy. An example is PSMA avidity on a PET scan to decide whether somebody would benefit from an anti-PSMA radioligand therapy. We've seen this example already, an FDG PET scan on the left, which is completely negative, a PSMA PET CT scan in the middle, before and after lutetium PSMA therapy. The presence of PSMA avidity on a PSMA PET CT predicts for a response to anti-PSMA therapy, and you can see that this has also been tried out in a phase 3 clinical trial where there was a improved overall survival of lutetium compared to standard of care, and this has resulted in the FDA giving a breakthrough status to this particular drug for consideration for licensing. Now, the type of biomarker, its context of use, and the patient risk determines the level of evidence you need for a regulatory qualification. Now, clearly the level of risk increases as you go from a diagnostic to a prognostic to a predictive biomarker. Similarly, if you're going to use a biomarker just for diagnosis, that has the lowest risk for patients. But if you're going to use a biomarker for decision support or for directing a therapy, such as anti-PSMA directed treatment, then of course you need a higher level of evidence. So the context of use is it going to be used as a diagnostic aid, a stratification tool for clinical decisions, or for directing therapy? And of course, the level of evidence increases. And it is the matrix on the left that determines the level of evidence that you'll need. So if you are using something like a weighing scale to inform on the management of weight loss, then of course the level of evidence you need that your weighing scale is accurate is of course low. However, if you were developing a defibrillator device to treat or diagnose a critical condition, then of course the level of evidence is much higher. In this context, multiparametric MRI for prostate cancer diagnosis is considered as intermediate risk because it is used to make a diagnosis and to direct a biopsy, but goes no further in its context of use. Of course, there are other things we need to think about in terms of level of evidence considerations. So we said that the type of biomarker is important, its context of use is important, and the clinical condition for the patient is also important. But there are other things that are also important. Is there a plausible biological relationship between the biomarker and the outcomes or the therapy? How reliable is the biomarker assay in terms of its sensitivity to change, its specificity, its sensitivity, accuracy? What type of data do you have to support the association of the biomarker with the context of use? Is it retrospective, prospective? Is it from a randomized controlled trial? How reproducible is this? Is this just in one study? Or have there been multiple studies? And were the statistics appropriate and pre-specified? The important thing for you to remember is just because you meet a regulatory requirement for a level of evidence does not mean that the biomarker will eventually be clinically valued. So let's take this example of a man with a high-risk prostate cancer. You can see on the right-hand side, the PSMA PET-CT scan shows you a number of nodal metastases in normal-sized lymph nodes. Now it turns out that PSMA PET-CT scans are better at ruling in disease than ruling out disease. So you can see that the positive predictive value of PSMA PET-CT for all nodes or larger nodes is greater than for conventional imaging, and the specificity again is higher than for conventional imaging. You can see that the sensitivity for PSMA PET-CT scans is not necessarily better than for conventional imaging. So it has a better rule-in performance than a rule-out performance. Now you'll notice on the basis of this trial, which was a prospective study, where there was no impact on management evaluated, where there was no impact on survival outcomes determined, the FDA still approved it. However, you have to remember that clinicians are pushing back from this minimal standard. They are saying that imaging should predict, prognosticate, and enhance treatment decisions if they are going to be clinically valued. In other words, they should maximize treatment benefits, minimize undertreatments, reduce or even prevent overtreatments while tempering costs and toxicities. In other words, clinicians to clinically value imaging as a biomarker are requiring a higher standard, but that is not required by the regulator. So this is the key take-home point. Higher levels of evidence are needed for more clinically impactful biomarkers for more serious health conditions in a risk-based approach. So the highest level of evidence will be for predictive, and then for prognostic, and then for diagnostic biomarkers. There is no regulatory requirement to show management or outcomes impacts for a diagnostic biomarker. If prognostic and predictive biomarker value is shown, then its value obviously increases. Prognostic biomarkers should focus on risk stratification management impacts, with secondary impacts on the quality and the quantity of life. However, predictive biomarkers should be evaluated as therapeutics, focusing on the quality and the quantity of life. Thank you very much for listening. In the next lecture, we will talk about how to build clinical value of imaging biomarkers.